Chair of this BPRS symposium by Dr. S.K. Kabra on challenges in management of cystic fibrosis in India. It's a great pleasure to introduce a person like Dr. Kabra, who is already very well known to all of us. It's very difficult to summarize achievements in few minutes, but just to complete the custom, Dr. Kabra is presently the Professor of Pediatrics, looking after the Pulmonology Division at All India Institute of Medical Sciences in New Delhi. He is Editor-in-Chief of the Indian Journal of Pediatrics. He has a long list of research papers, more than 900 papers. He has chaptered more than 200 book chapters, and he has 15 orations to his credit, and he has innumerable guest lectures delivered all over the globe. He has more than 12,000 citations for his publications, and his prominent books, which he has written, are Essential Pediatric Pulmonology, Essences of Tuberculosis in the Pediatrics, AIMS PICU Protocol, and Case-Based Review in Pediatric Pulmonology. Over to Dr. Kabra.
Thank you, sir. Respected chairpersons and friends, in next 16, 17 minutes, I'll try to finish it. I can take a privilege of extending it because I am probably one of the oldest person, one of the oldest, 65 years. Okay, so this is the common problem of respiratory system in India, pneumonia, TB, asthma, which we are discussing. Overwhelming prevalence of common problems and limited resources compounded by the basic principle of medicine that if I make a common diagnosis, I'll be more right. If I make a rarer diagnosis, it would be, I'll be more wrong. So we find difficult to think beyond these common illnesses, and the consequences are diagnosis of rare diseases are missed, training suffers, young pediatricians look towards higher income countries for training. The diagnostic tests and treatment are expensive and difficult to replicate. So there is a rapid dissemination of advances in diagnosis, as we have learned about the CFTR modulators now. And world has become so small that information of new treatment is available within few hours. However, there is a discordance between the IT and development index of different countries, and additionally there is an increased interaction between patients in different subcontinents by social media, increased expectations from doctors, and medical fraternity knows advances in the management, as all of us are aware that CFTR is a wonder drug and that should be given to each and every child, but we'll see that what are our challenges, and there is a frustration among the physicians, pediatricians, as well as among the patients. So what is the way forward for us? Can we follow the guideline protocol used in the developed countries? Possibly no, as resources are limited and priorities are different. Shall we wait till our resources are better? Like, shall we wait till 2047? Probably not. Not sure how much time it will take. And what shall we do now? So our aim should be to provide a first-class good care to our patients, but we have to wait, and ultimately we have to reach to that stage. But till that time, we have to develop our low-cost diagnostic intervention that is suitable for our situation. So let us see that, is it really a problem of CF? So the migrant population in US, it was considered to be around 1 in 40,000. This is based on the migrant population from the Indian subcontinent, which includes all the 3 countries. And migrant population in UK, in the middle part of the UK, it was based on the 2 patients, and it is 1 in 10,000 to even in 12,000. And this is the data which we published some time back, that how many cases have been reported, and you can see that there are so many reports. And in the next slide, you can see this is the almost 2 decades ago we published that the patient's place of residence, it is spread all over. Some of them were from here also. And the CF place of origin, you can see they are from all the 3 subcontinents. So it is occurring in all parts of our country and in our subcontinent. And this was a small study of 950 cord blood tested for Delta F508, and we calculated that it may be 1 in 40,000. But I want to bring this notice to all of you that a recent study published from Gangaram by Dr. I.C. Verma and his group, they tested 200 participants. And they found that at least 52 were found to be carrier of one or more of the rare diseases. This was a low-risk group, say 26%. 9 individuals were observed to be carrier of cystic fibrosis with the frequency of 1 in 22, which is considered to be 1 in 25 normal in UK. So it is almost similar, provided that the same type of data are replicated by other studies, suggesting that possibly we are missing the diagnosis of CF. We may be having a similar incidence as that of a UK or other Caucasian population. What are the challenges? Ignorance of physicians, diagnostic tests not available, lack of experience, medications recommended in various guidelines are very expensive or not accessible, lack of trained manpower, and not support from the governmental agency. So though there are challenges, but I'll just try to discuss what are the solutions. So ignorance of pediatricians about the phenotype of CF. Due to strong belief that it doesn't happen in India, it is not taught in the medical school, but now the scenario has changed. Majority of pediatricians may not have seen a diagnosed case of CF, their diagnostic not developed, and delayed diagnosis and treatment leading to an advanced disease. And how we improve the awareness about the CF among pediatricians. So whatever I give a significant praise for Gary, Julian, and under the team, under the leadership of Dr. Chris, they helped us in developing CF services at AIMS, started in 1996. So we developed a module. Me, Dr. Meenu Singh, Dr. Raju Khubchandani, and Dr. Venu Gopal in 2005 went to Southampton, stayed at his home, and then we developed, this idea came, and then we developed how we can manage this at our place. So you can see that there is an increase in the number of publications from India on cystic fibrosis. So it is an improved scenario due to multiple factors, not entirely related to our efforts. But as I said, as far as CF services at AIMS is concerned, I give full credit to Dr. Gary, Julian, and under the leadership of Dr. Chris. Diagnosis, sweat test is not available. Mutations are very heterogeneous, that you will be seeing in the next slides. And we developed the indigenous method, which costs around $10, and ongoing cost is around $0.3. And this is also available in our country. The cost is significant, and there is a ongoing cost is more. Say now the basic equipment may cost around 25 to 30 lakh rupees, but ongoing cost is between 5 to 7,000 rupees. So that's why we validated our system, and it is working very well. So sweat test facility in 1999 was at 4 centers. In 23, there are multiple centers, but it is grossly inadequate. We need at least one center doing it at least in 1 to 2 districts. So now let us see the genotype. Commonly, it would be, as you had seen in the Julian's presentation, that 80% of their patients was homozygous for delta F508, but the same thing is around 20 to 30% in India. And this is the frequency distribution of CFTR mutations, and you can see this is by the NGS done by our genetics unit, and part of the CAR project, that it is so heterogeneous. Still delta F508 remains the commonest. So you cannot use delta 508 testing, and then if it is negative, you say that CF is ruled out. Okay, so then our team worked on another test, screening test, that is aquagenic wrinkling, in which you dip the child's hand in water at room temperature, and then you see at 3 minutes how many children has developed, whether he develops a wrinkling, and the sensitivity, it was present in 81%, but specificity was only 57%. And this is just to show you that how you can perform aquagenic wrinkling. Wherever you are working, you can just check the child's hand, put it in the water at room temperature, see after 3 minutes if there is a wrinkling with a clinical background. As we were worried that the specificity is very low, 57%, that's why there is a need for further investigation. So we developed 2 scoring system to prepare an algorithm for screening children with cystic fibrosis when sweat test is not available. So you can see here, these are the, if you, I'll be showing you, not showing the details of what were the variables, but I'll show you the algorithm. So you can make a diagnosis of CF by common investigations including history and examination with the normally available tests. So this is not this is based on this our algorithm which we developed by checking who are having a cystic fibrosis as gold standard by the sweat test and then their clinical features and common tests. And you can see that this has a reasonable area under the curve of 87% and 85%. So that's why we thought that probably this can, our screening system can be improved. So I am not going in the details. If someone is interested, it was published last year in pediatric pulmonology, can go through it. So suspect CF, if a child presents with a recurrent persistent pneumonia with bulky fatty stools or failure to thrive, and if there is a history of CF death due to any respiratory illness, not because of cystic fibrosis, but any respiratory illness, and sputum is positive for Pseudomonas, if it is there, then you can make a diagnosis of CF with a sensitivity of around 85% and same is the specificity. But confirm the diagnosis by doing a sweat test subsequently. And if none of these things are there, then check for the aquagenic wrinkling, hyponatremia, metabolic alkalosis, and stool fat globules. These are the 3 investigations commonly available or may be made available, and then you make a diagnosis of probable CF and start the treatment. So learning management of CF, you can see Gary. So this is 2006 probably. So we contacted Dr. Krish when I was with my wife in Manchester, and she was doing a BPS fellowship. And then we had a twinning with Southampton unit, exchange visits. Their team, along with their dietitian, physiotherapist, and themselves, including Julian, they came, made several visits to our CF clinic. We learned from them because I did not have any exposure to CF during my MD. I had not seen even a single case. So I learned how to manage these patients from their team. And this can work similarly with us also, that we can use our few centers and then we can do a twinning. People can come from the other part who want to learn. And we developed a suitable protocol which is suitable for our country, aggressive physiotherapy, which is neglected. And we need to develop our good manpower to do aggressive chest physiotherapy. Physiotherapy as of now is just a postural drainage or training is lacking. Regular follow-up education of CF family, create a self-help group and use of a low-cost intervention in form of azithromycin and hypertonic saline. Identify some institution, as I said, and then we train ourselves, our manpower. Then management. Medications were not available till 2004. These enteric-coated spirules in form of a creon were not available to us. Mucolytic is still expensive. So we developed our consensus protocol for management. So now we see, Gary may recognize this when we came to Southampton, Chris has used this thing, that if you are counseling clean environment, dietary advice, physiotherapy, it doesn't add any cost to your treatment. Basic radiology, lab test, vitamin and salt supplement, bronchodilator and hypertonic saline, it may be around 2,000 rupees a month. Pancreatic enzyme supplement, microbiology culture and antibiotic IV SOS, it may increase to 5,000 rupees. Inhaled antibiotic in form of tobramycin, advanced radiology, it may increase to 20,000 rupees because only inhaled antibiotic may cost significantly. If you add DNAs, then it may increase 95,000. It will be from the grey market and one respule will cost you around 2,500 rupees. And if you add Trikafta, then 25 lakh rupees a month. Another company from Argentina may be marketing it with a 9 lakh rupees a month. That is also significant. We do not have much experience. Only 4 patients are on CFTR modulators. 3 of them are on Orkambi. In one, we had to stop because his FEV1 was 30% and he developed a significant hypoxia and headache after the first dose of Orkambi. Trikafta, one child is getting, she is doing very well. And important thing is that the area of maximum cost benefit is here. If you can go up to here, and here it decreases. The output decreases significantly. So not to worry if we do not have a Trikafta, not to worry, but give supportive care. So where should we put our efforts? So this is the data from our cohort that if a patient is diagnosed late, if there is a Pseudomonas, if child is malnourished, and if he is colonized with Pseudomonas, all of them will reduce their survival. But if we can identify them early, institute appropriate treatment, prevent their Pseudomonas infection, we may be able to improve their survival. So what is the low-cost treatment? Hypertonic saline, azithromycin, aggressive physiotherapy, not to restrict food, electrolyte supplement, and fat-soluble vitamin. Chest physiotherapy, as I said, is one of the most important but neglected part, and we need to create a manpower or physiotherapists trained in chest physiotherapy. How to get appropriate treatment for patient? Management protocol as per available resources, self-help group, fund generation, and support from government. Government has started rare disease policy, and in that, CF patients are eligible for getting 2 types of help. One is 50 lakh rupees, which can be used over next 10 years. So we should try to encourage our patients to submit their application for support for medications. That will not be useful for Trikafta because that will be utilized in 2 months itself. So how we improve visibility? Generate data, involve policymaker and CF registry. We have started CF registry, though we had worked with Gary for starting CF registry here, but it did not work because of the pandemic. But it is now there and we'll extend it. So what are the challenges? Cystic fibrosis occurs in all ethnic groups. Significant problem in diagnosis and management, and what is the way forward? Create awareness among pediatricians by small workshops, use sweat test as a gold standard, use country-specific treatment protocol, but I'm not restricting. We should aim for giving good services, including Trikafta and others. Ensure regular follow-up, aggressive physiotherapy, hypertonic saline and azithromycin, self-help group. Our patients are managing a CF trust with who are buying medications directly from the companies and providing it almost 40 to 50% less than the market rate group, and use rare disease policy. Thank you very much.
Any questions?
Okay, we tend to use the higher concentration. There is an issue about giving a test dose to make sure it's tolerated. Hypertonic saline can cause bronchoconstriction, and you may need to predose with a bronchodilator, give some salbutamol if that does occur. But I think there's good evidence for a dose response between 3% to 7%. So if you can use 7%, use it. If your patients are having a tolerance issue, try salbutamol before. If you're still struggling, then you could use a lower concentration, I think I would advise.
Because we have an Indian study from AIMS, New Delhi, done by Dr. Kabra, which showed that there is no significant difference between 3% versus 7%.
I guess it's going to be quite hard to measure differences in terms of clinically important outcomes.
Because commercially 7% is not available freely. Now one company has started, so pharmacists were giving it just without observing any precautions. So they were getting fungal infection. That's why we did a randomized control trial, and we found that as far as improvement in the respiratory function and parents' acceptance is concerned, it is equal. And with 7%, as obviously it was expected, there was some increase in the cough and cold, after giving this 7% saline.
I hear all of that. The thing to remember about hypertonic saline is it only has a very short duration of action. So you're giving it as an adjunct to physiotherapy. It's working for about 60 to 90 minutes to improve mucociliary clearance. So get some physiotherapy in with whatever concentration you use to get the maximum benefit from doing that treatment.
Thank you so much, Dr. Kabra. With this, ma'am, please.
One is just wanted to compliment Dr. Kabra for such a beautiful talk. We always have been having challenges for managing patients of cystic fibrosis. And since I moved from Chandigarh to Rishikesh, and now I find that possibly there is something in indigenous medicine which may be helpful for cystic fibrosis. I'll just quote 2 examples. One was, of course, the study was done a long time ago on curcumin. And it was found to correct the defect of delta F508, although those studies were not replicated, but happened sometimes very early in 2000s. And probably the way curcumin is used in India, along with certain other things, probably masks the expression of the gene, which has been found to be of such high frequency, if you believe Dr. I.C. Verma's results. That is point number 1. The second one is about the use of phages, which Gary mentioned in his talk about bacteriophages, the viruses which are there in the environment, and in fact in water. And it's been shown that Ganga water, the river Ganga, which flows in Calcutta as well as in Rishikesh and Haridwar, it contains certain phages which have been typed and which have been shown to inhibit Pseudomonas, which is biofilm forming. And I think there has been some research on this in All India Institute of Medical Sciences by Dr. Rama Chaudhary as well. And there is a group which is working in Rishikesh also who show that if you put that water drop on Pseudomonas, it kind of clears up.
Yeah.
And so I think there is something which we need to do more because things are very expensive. Trikafta is very expensive and cannot be afforded. So let's work a little more on
we are waiting till 2025 when this thing goes off, and then our companies will make it very cheap.
If you can look at these molecules, use some pharmacogenomics and see that some of these molecules can be replicated, and whether they're already existing in the environment. Thank you.
So curcumin as well as gentamicin, that has been used for a stop codon type of mutation, and then haldi, which is one of the common spice which is being used, though it is very small amount, and it may not be able to provide the concentration of curcumin which we expect in the experimental studies. But it may be, as Dr. Meenu says, it might have modified the course of illness, and that's why we are finding less number of children with CF, but it is just a hypothesis.
Sir, what is your experience and role of regular IV therapy, IV antibiotic therapy in stable Pseudomonas colonized patients? Any experience?
We do not follow it regularly unless it is indicated as per the clinical condition. But in UK, some of the units are using every 3 months IV for 2 weeks. Probably it was in London.
We did have some patients that were using it every 3 months.
Some units are using even in Norway.
Yeah, I think it was certainly something we did.
And they show that it works. But I have not come across any randomized control trial of as and when required or regular IV. So as of now, we do not use it because it is difficult. Logistics are not working very well.
There is one RCT and it showed no difference in the UK, so yeah.
If there are no other questions, we will conclude this session. Thank you all for their wonderful lecture. Thank you very much.